they've pulled together. First, before we get started, before I forget, there is no CME code for today's activity. So if you're looking for the CME code, it doesn't exist. For those of you who've been through this before, we're going to have 4 presentations by our trainees, 4 oral presentations. Annually, we have a selection committee that reviews all of the submissions and selects a few presentations for oral presentations during this Grand Rounds hour. And then for those of you who are here in person, we have our poster presentations out in the hallway. We're going to have the authors standing at their posters between about 9:15 and 10:15 to present their findings. And then we're going to reconvene back here in 1302 around 10:15 and award some honors to posters that were presented out there. We're going to we have a selection committee that's going to be going around and evaluating the posters. I just want to start with a few remarks and then introduce our chair of medicine. As you know, I'm the vice chair here in the Department of Clinical Research, and I think this annual day really is I think one of the most important things we do as a department. We spend a lot of time for our faculty and our medical students, our residents, our fellows, spend a lot of time in patient care. That's our main mission here, is taking care of people. But the ideas of, where do those great ideas of how to best take care of our patients come from? It comes from discovery. It comes from people just like you who have had ideas of, we usually do things this way, but I'm finding that if we try to do things a different way, people actually do better. They improve their health. Disease is treated more quickly and more effectively. Maybe we should look into that. And I just want people to think about many of the great discoveries that we have in science and in medicine come from people who are early in their careers, because they're the people who are most likely to be questioning how we do things. Once you get old like me, you just kind of get into a routine and just accept things and take it for granted. But when you're just starting out, you're always questioning things. That's really where the new discoveries come from, and really the advances in our field come from. So as you're going to see in these presentations from our trainees, it's excellent science done in an excellent fashion. And hopefully a lot of what is presented today and a lot of ideas that you all may think of over the next 5, 10, 20 years will become new discoveries in the field of medicine and will advance how we take care of people. So I just encourage people to think outside the box. And if you have a good idea, to pursue it from a research standpoint in trying to find out, get to the bottom of that research question. So without further ado, I'm going to introduce our chair of medicine, Dr. Jean Clark, for a few opening remarks.
Thanks, Mike, and good morning, everyone. I also want to welcome you to this amazing day. It's a lot of fun. I'm very excited to be here with you. Like others, I want to thank everyone who's made this possible. And I don't think they're here yet, but I want to thank the Sadani family for their generous gift that makes this event, and actually a couple of others in the department, possible every year. I think many of you know that the bulk of my career has been as a physician scientist, doing clinical research in the area of metabolic diseases, especially obesity, diabetes, fatty liver disease. And the last few decades, I think Mike didn't touch on this exactly, the last few decades have really been remarkable in terms of discovery and then translation of that discovery into clinical practice, which is what stems for these questions. I don't think you have to think that hard about how quickly the COVID vaccine came into the market, got to patients, got to the providers to protect them. Think about the advances in oncology, in rheumatology. Think about the GLP-1s. This has really been an amazing time to be in research. But I think what many of you don't know is that I actually came to research fairly late. I did a little bit of fruit fly research in college. Wasn't that exciting to me. I never really thought that much more about it. And it wasn't until I was a senior resident and a chief resident, as I thought I really wanted to stay and be in an academic career, that I really started to think about research. And so then from there, I went from residency and did a general internal medicine fellowship, which is really a clinical research fellowship. And I got my MPH and I started to get into research. And that's what launched, number one, my love for doing research, and number two, my research career. And that's been actually incredibly rewarding, and nothing I would have thought about when I started into medical school, not what I was thinking about when I was in college, was really when I got to that point. And so I think it's a nice opportunity today, on a day like this, for the trainee research day, to think a little bit about the physician scientist and the role of the physician scientist. It's actually pretty rare, but it's really precious commodity. And I think it's rare because a lot of people don't really understand what it means or what it takes to be a physician scientist. I'll tell you what it does not take. It does not take, you do not need a PhD. I don't have one. You do not have to have started in high school or really even in college, right? And you don't need to do basic science or basic research, although you can, and that's incredibly important. But you could do anything along the spectrum of research. To be a physician scientist, you do need to be a physician. You do need to have training in research, and you can get that in a few places. And you do need, as Mike said, to sort of be curious and be creative. How can we do things better? What are the things we're not really treating that well? There are many of them still. There are many diseases that we really don't know what's going on, or that we really don't know how to treat well. We treat with a lot of side effects, or we treat suboptimally, right? So if you're thinking about this, if this day, if the project you've worked on is getting you thinking, or your first year, and you're thinking about this, I encourage you to spend some time with physician researchers. There are a lot of us around. There are many people who are doing this, and there are many here today. And I think the opportunity that research provides for you and the career that you can have is really amazing. And even if for some strange reason you don't plan to be a physician scientist, that's perfectly fine, obviously. It's important for you to learn about research and learn how to do research for a couple of reasons. Number one, maybe if you're not a physician scientist, you do want research to be part of your career. There are many places like here where we have people called clinical scholars who do research sort of part-time. There are many people who choose a path as clinician educators, but they do research too on what's the best way to educate the next generation. What are really the best methods to do that? And then both in academic practices and in private practices, many people get involved in clinical trials where they can enroll their own patients in the latest and greatest and contributing into that. And I would say to do all of those things, you need to understand research and you need to learn that. But even if you don't want to do that, your plan is to be an excellent clinician and devote your life to that, you still need to understand how to interpret the medical literature, right? Which things are ready for prime time, which things are the best and most applicable to the patient in front of you, that one patient in front of you, so you can really understand how to do that. So I encourage all the trainees here to try out a bit of research if you haven't already, to reach out and meet with faculty if you're interested to understand how their careers went, how they incorporate research into their careers as part of it or as a majority part of it. And if you don't know where to start, you can start with your program directors. You can start with Dr. Steinberg or Dr. Buettner here, who are vice chairs for research, and just reach out and try and connect. So I'll end by congratulating all of our presenters for today who are trying their hands at research. I want to thank everyone who made this day possible, and I hope you enjoy the rest of the morning. Thanks so much.
Okay, as David helped me pull up the slides for our first presentation, I'd like to introduce our two presenters for the first project, Dr. Ankur Patel, Dr. Arvind Busetti, and they're going to be presenting on continuous intravenous proton pump inhibitor therapy improves prognosis in critically ill patients with upper gastrointestinal bleed.
All right. I'd just like to thank everyone for selecting this as a poster presentation. I worked with an incredible team with Dr. Busetti, Dr. Chen, Jing, and Dr. Patel was our PI. The project's titled Outcomes Following Intermittent versus Continuous Proton Pump Inhibitor Therapy in Critically Ill Patients with Upper GI Bleed. I have no financial interest or relationships to disclose. So the background, as I'm sure everyone knows, we see a lot of patients in the hospital with upper GI bleeds. Upper GI bleeds can be divided into variceal and non-variceal upper GI bleeds, and that's important because non-variceal upper GI bleeds are predominantly peptic ulcer disease, ulcers that are bleeding, versus variceal, typically patients with advanced liver disease, portal hypertension, may have manifestations of the elevated portal pressures leading to these dilated veins in their esophagus. And the treatment for both of those are quite different. So typically for varices, we try to ban. For ulcers, depending on what it looks like, what features they have, we have a host of therapies, including epinephrine injections, sprays, gels, clips, and cautery. This project, we predominantly focus on non-variceal upper GI bleeds. The second bullet point is to kind of state the obvious in that we see a lot of patients. It takes up a lot of hospital beds, dollars, and there are plenty of studies that say that we'll probably be seeing more of this in the future. And when we do, it'll be older, these patients that are older, have had time to develop more comorbidities, and a lot of these comorbidities, like abnormal cardiac rhythms, et cetera, that require them to be on anticoagulation. So they'll be higher risk of bleeding and rebleeding. The crux of management for upper GI bleed can be divided into pre-endoscopic therapy, endoscopic therapy, and then what we do after. Part of pre-endoscopic therapy includes resuscitation, making sure that if they have any underlying coagulopathies, that we manage them, treat them, optimize them, and then to decide what of their blood thinners is necessary or how long can we hold it safely. And then PPI therapy, which is specifically what our project is going to focus on. A little bit of background. So acid secretion in the stomach is modulated by 3 different pathways. One is the histamine receptor, one is acetylcholine, and the other is gastrin. There's been plenty of studies that look at H2 blockers compared to PPI. H2 blockers essentially competitively bind to this receptor, and that in turn leads to reduction in gastric acid secretion versus a PPI, which acts on the receptor itself. So it's not surprising that PPIs have been shown to overall lead to greater acid reduction compared to a H2 blocker. Why is reducing acid secretion important? Because leading to a higher pH in the gastric lumen is associated or required for normal clotting function, including platelet aggregation, fibrin formation. A pH less than 5.4 essentially makes that very difficult. I think that there's a discussion on how we optimize PPIs in patients, and it is not necessarily, how much drug we're giving at one given time, seeing what their maximum concentration is in their serum that aligns to their ability to reduce acid. It's been shown that acids or the reduction in acid secretion is related to total dose given and area under the curve. So what that means is that it is the concentration of PPI within the serum and how long we're able to keep that at a steady rate. And that's affected by a couple of things. It's affected by rate of elimination. There's some studies that show that patients, some are quick metabolizers, some are slow metabolizers. PPIs are often eliminated or metabolized in the liver, so it gets metabolized by CYP enzymes, and certain patients that are on other medications can affect whether the CYP enzyme is kind of upregulated or inhibited. And then the other more important focus of our project is fluid shifts and blood loss. Typically these patients, especially the ones that are critically ill and bleeding maybe more profusely, come in and they're given sometimes an injection of a PPI. Between that and the next 6 to 8 hours, they're getting multiple liters of fluid, multiple units of blood, and they're also losing said blood within their GI tract. So how much of that is actually getting to the receptor is unknown. So we kind of thought about this project and kind of opening up this question on what route should we give PPI and what frequency, and how can we best optimize them prior to an endoscopy. There's been plenty of literature that has mentioned that continuous therapy and intermittent PPI therapy that is equivocal. There's a meta-analysis that included 13 randomized trials. The 13 trials were done in Asia, so it's kind of hard to generalize outside of that country. And they also looked at all patients, so they didn't necessarily specifically focus on patients that were having evidence of a more brisk GI bleed. And then in our second study, or in the second bullet point, it was a retrospective multi-center study, including over 400 patients. And what they saw is that continuous IV PPI therapy had a high rate of rebleeding. However, in this study, patients on the IV PPI drip had a lower average hemoglobin on presentation and a higher heart rate on admission, so they were sicker patients. And that study also did not document source of bleeding, ulcer or forest classification, and therefore it's really hard to figure out why, or it's really hard to confirm whether that's true. Also, the continuous IV PPI therapy, the patients in that cohort had a higher likelihood of having liver disease, alcohol use, and variceal bleeding, which again agrees with that these patients were sicker and also may have had a different source of bleed for which PPI does help, but it's not the crux of therapy.
The other thing too is for an example for the ICU, I know that many people rotate there. The Pepsid trial actually showed that in PPI specifically, there is an increased risk of pneumonia and other complications. So, one of the things that we try to do for hospital utilization is try to prevent people being on prolonged PPIs if possible. So we wanted to look at whether or not continuous or intermittent PPI therapy would actually provide a morbidity, mortality benefit for these critically ill patients.
Our research aim was to compare continuous, PPI drip versus intermittent PPI, typically, the 40 milligrams twice a day that we give among patients that are admitted with non-variceal upper GI bleeds and critically ill patients. Our aim was to assess outcomes, including mortality, length of stay in these patients. We used a database called the Medical Information Mart for Intensive Care, MIMIC-4. It is a database that has de-identified medical data of over 40,000 patients who were admitted into the ICU at Beth Israel Deaconess Medical Center between the years of 2008 and 2019. And we were able to pull patients from this database using ICD codes. So table 1 is a table that has demographic characteristics, and this is after we did propensity score matching. So what we did is we matched patients 1-to-1 with age and sex controls. And so part of that is that we're also matching, because we're matching patients due to age, we're somewhat doing a good job at matching patients by comorbidity. So what's not shown here is the distribution of comorbidities per cohort, but they were all, especially the comorbidity index, Charlson comorbidity index, they were all equal. The only caveat is that the intermittent PPI therapy group had a slightly higher prevalence of liver disease. I think it was a difference of about 8%. I don't think it was statistically significant, but it was approaching it. Our average age for our patients were middle-aged, around the age of 65. A majority were male and of white race.
And with our propensity score matching, the racial distribution was pretty similar between the groups. There was a little bit more patients with Hispanic and Asian origin in the PPI drip group, but not significant difference.
Our second table kind of shows the outcomes between these two groups. And so what we're seeing is a significant decreased mortality rate in patients on continuous PPI therapy, as well as decrease ICU length of stay and overall length of stay, which was a little surprising just based on how drastic these results really were. We weren't expecting this to this,
Degree.
to this degree. Table 3 shows a Kaplan-Meier curve, and we did it by 14, 30, 100, and like 1,500 days. And so this table shows our Kaplan-Meier curve at the 14-day interval. And the reason we show this is that we're really seeing the reduction in or the increased survival somewhere, start to form around somewhere between day 6 and day 10. So one could, postulate that this is well after they're admitted, probably have had their endoscopy and kind of towards, the middle end or late end of their stay, where we're really seeing the survival benefit. The only, caveat with our study, and I guess I'll touch on it a little bit later, is that it's very hard to tell whether patients switched from the continuous therapy group to the intermittent. If they were in the continuous therapy, when did they switch to the intermittent? And I think we can assume that they probably all were, or else, this hospital was probably going to go bankrupt at some point.
And within the first week, it seems like within the first week of starting PPI, it seems that there was a pretty significant amount of overlap between in terms of survival. But as we go towards 2 weeks, which how many patients are actually still on a PPI drip for 2 weeks straight is hard to surmise. So.
And this kind of just shows that, once we kind of pull out the Kaplan-Meier curve up to 100 days, there is, a significant survival benefit in those patients that had received the continuous IV PPI therapy. Limitations, I already touched on one. So, difficult to distinguish when or how long they were on each therapy for, whether there was overlap, like Arvind said. And how long in total did they have each therapy or IV PPI therapy in general? And then what were they discharged on? Were they discharged on a regimen that made them more or less prone to developing, complications or rebleeding following discharge? And whether the patients were really adhering to their medication ultimately. Mm-hmm. And then the database didn't provide any information regarding endoscopic findings, when the endoscopy was done, what interventions were done, which is very important because we typically classify ulcers based on Forest classification. And the reason we do that is because there's been plenty of studies that show that certain ulcers with certain risk appearances have a difference in rate of rebleeding. Our conclusion is that in critically ill patients admitted to the ICU with a non-variceal upper GI bleed who did receive continuous infusion PPI therapy did have overall, improved outcomes, including mortality, length of stay, compared to those that did not and did receive intermittent PPI therapy. We're not necessarily advocating for us to really expand the, continuous PPI therapy just yet, but I think we want to kind of reopen this question and determine which patients do we think would actually benefit from the continuous PPI therapy. And those are the ones that are critically ill, have features like they're having, a more profuse bleed, and they're especially, getting resuscitated by multiple liters of fluid and units of blood, and perhaps other risk factors, including coagulopathies, and their anticoagulant use, or maybe they're not on it. And therefore have a discussion on how to optimize their therapy before endoscopy.
And for future study, taking this to the single center world and trying to utilize continuous versus intermittent PPI therapy, and seeing endoscopic therapy, Forest classification, and trying to differentiate what aspects of those patients in the critically ill setting may also help provide some information onto what therapy may be better, possibly adding on H2 blockers into the study, as well as Dr. Patel was mentioning, that there is meta-analyses and retrospective studies that kind of differ in their outcomes between the two. And then additionally, seeing these patients on follow-up at a GI clinic to see how they've been adhering to the therapy and what therapies they've continued. Would be, of course, long study, but would help provide us more information.
Here are some of our references, and then we'll take questions if anyone has any.
The physiology.
I think I'd ever do that.
Question with just repeat the question quickly.
Oh, I honestly forgot the question, like the whole question, but I think the question was that, sicker patients, do we expect them to get continuous IVE PPI therapy? And also, how are we going to address, or how can we control for their comorbidities that make these patients sicker, to kind of have a better comparison between the two groups?
Charleston,
Yeah. So I think that one, with the kind of publishing of some of these studies that show that the continuous PPI therapy versus intermittent is non-inferior or equivocal, I think a lot of people are turning towards just intermittent PPI therapy for all patients that come in with an upper GI bleed. In fact, I don't even think we can order a PPI drip on our Epic as of the last 6 months, which is different than when I recently graduated residency. So I think that, the hospitals trying to save costs, cut costs. I think we're trying to make a push for intermittent PPI therapy, but I think we need to kind of ask, bring this question back up to light and see whether intermittent PPI therapy is, in fact, the best course of action in these patients that are sicker, like we're trying to examine here in the study. And then to answer the second part of that question, how can we address for the comorbidities of these patients? I think we can probably match. So what we did is we matched along Charleston Comorbidity Index, but I think we can match respect to specific comorbidities that are more, indicative of patients that are sicker in terms of their risk of bleeding, or their risk of bleeding, that being anticoagulant use, so AFib and other comorbidities that require these patients to be on a blood thinner, liver disease, coagulopathies, and target specific comorbidities that way to really have a more balanced comparison.
Propensities.
We did a propensity score matching. Yeah. But we did it mainly age, gender, and Charleston Comorbidity Index as a whole.
What makes it difficult is that in clinical practice now, there's a lot of different scoring systems for a lot of very specific indications, like, for example, the Has-Bled score. It's hard to control all those things between patients because in the critically ill patient, most of the time you're worried about continuing PPIs and increasing risk of C. diff or pneumonia and other things like that, which is, I think, one of the reasons why we try to stay away from a drip therapy or a drip rather than and doing intermittent instead. Another thing that we could do in future study is to determine, like, the risk, is it actually increased with those complications between drip and intermittent, to kind of steer people towards, okay, there's actually really no difference, then maybe we can test this a little further.
We're going to move on to the next meeting. Thank you guys very much.
Hey, wonderful. So our next presenter is Dr. Julia Nelson. And Dr. Nelson is going to be presenting on breakthrough invasive fungal infections in AML, MDS patients on antifungal prophylaxis.
Hi, good morning, everyone. And for those of you I haven't had the chance to meet yet, I'm Julia. I'm one of the third-year residents, and I wanted to talk about my research on breakthrough invasive fungal infections in AML and MDS patients receiving antifungal prophylaxis. We have no relevant disclosures. And for a little bit of background information, as I'm sure everyone's aware, patients with hematologic malignancies are at a high risk for many types of opportunistic infections, including invasive fungal infections due to their neutropenia and their associated chemotherapies that deplete their immune systems further. The current IDSA and ASCO guidelines recommend that these patients who are at risk for fungal infections receive mold-active primary antifungal prophylaxis. And the at-risk patients that they define include patients who have AML myelodysplastic syndrome or patients who are undergoing hematopoietic stem cell transplant. However, despite appropriate antifungal prophylaxis, breakthrough invasive fungal infections, or BIFIs, as I may refer to them throughout this talk, can occur. And these do remain a significant cause of morbidity and mortality in this patient population. There are multiple different antifungal agents available on the market, but there's somewhat limited data comparing the efficacy and side effect profiles of these different agents. And the data that does exist has relatively small trials. So this is definitely an area that warrants further investigation for this patient cohort. And just a little bit of background information and definition housekeeping before we get started. There are different categories of breakthrough invasive fungal infections that we can talk about. The first is a possible breakthrough invasive fungal infection. This occurs in a patient who's the right host for breakthrough invasive fungal infection. And for the purposes of this talk, everyone's the right host. There's some sort of clinical feature concerning for a fungal infection, whether it be based on physical exam, history, or some sort of imaging finding. But there's no discrete mycological evidence of fungal infection. And by this, I mean there's no biochemical signal that there is a fungus active and causing trouble somewhere. And so we have a lot of surrogate markers as opposed to true culture that are pointing towards fungal infection. These are things like beta-D-glucan, which is our Fungitel assay, Aspergillus galactomannan assays, which can be sent from the serum, can be sent from BIL studies, and things like that. So they can kind of approximate a fungus and indicate that, yes, one may be present. A probable invasive fungal infection is when you do have this mycological evidence that there is some sort of fungal disease. And then proven is probably the most straightforward, where you have some sort of culture or pathology tissue diagnosis that confirms the fungus is present. With respect to proven breakthrough invasive fungal infections, sometimes they are quite hard to really prove because fungus doesn't always grow readily in standard culture media, and sometimes, especially in this patient population, obtaining a tissue diagnosis or pathology is quite difficult. You're not going to take your newly diagnosed leukemic with 3 platelets for bronchoscopy with biopsy sometimes. So the objectives of our study were to evaluate the risk factors and incidence of BIFIs between the different types of antifungal prophylaxis and determine the efficacy and side effects of the different mold-active prophylactic agents, including posaconazole, voriconazole, and isovconazonium, or Cresemba, brand name for it. And then our hypotheses were that posaconazole would be more efficacious compared to the other agents, and that there would be conversely an increased breakthrough rate in patients receiving voriconazole or Cresemba. And this has been hinted at in some of these smaller studies that have been coming out in the area. And then our other hypothesis was that there's an increased breakthrough risk in patients with AML who are undergoing induction chemo, who have relapsed disease, or those with stem cell transplants. So in effect, the sicker patients. And with respect to our methods and data analysis, we included adult patients with AML or high-risk MDS who oftentimes receive the same chemotherapy regimens who were admitted to our institution at some point between January 1st, 2020 and December 31st, 2022. They had to have received prophylaxis with one of the following agents for at least 7 days. Patients who are excluded are those who had another type of hematologic malignancy, pediatric patients, patients who were simultaneously getting additional antifungals in conjunction with these oral agents, patients who had previously gotten amphotericin or who had a history of prior or active fungal infection at the time of study beginning. We took a lot of time and reviewed the medical records for these patients, collecting data on the antifungals used, the reasons for switching, when and why antifungals were switched, and the presence of breakthrough infections. And then if a breakthrough infection did occur, we did collect additional data about the clinical situation, such as their immunocompromised status, their chemotherapy plan, what stage they were in their AML diagnosis, et cetera. And all of this was entered into a REDCap database. And our endpoints were probable or proven breakthrough invasive fungal infections, patient mortality, or the end of our study window, which is actually the end of 2024. This is a subset of an ongoing project. And then the information regarding the BIFIs was extracted from the REDCap and analyzed in the very high-tech Microsoft Excel. So for our demographics, our study yielded a total of 270 patients. Slightly over half were males. They had a mean age of 64 approximately years old. And we had 64 patients experience a total of 82 breakthrough invasive fungal infections. This is a quick highlight of the antifungals which we had used at our institution over this time period. As you can see, voriconazole was by far the most commonly used antifungal, followed by micafungin. And then this is a slide that illustrates the number of breakthrough invasive fungal infections that occurred. So, okay, you can see my mouse. We had a total of 82 breakthrough invasive fungal infections. The vast majority were possible, so 50 of them were possible. So this was some leukemia patient who came in with a fever, had imaging, had some sort of suspicious looking nodule on CT, but that's about it. We had 21 probables and then 11 proven breakthrough infections. If we're looking at just sheer number of breakthrough infections, 33 of them occurred on voriconazole, and then followed by 17 on micafungin. And to try to standardize based on how the different frequencies of antifungal use, I calculated a rough incidence, which was just the total number of breakthrough infections divided by the total number of patients who received the antifungal. Interestingly, posaconazole actually had the highest incidence, which kind of went against our initial hypothesis. And these were some of the risk factors that were identified for breakthrough invasive fungal infection. By far the most common risk factor was prolonged neutropenia for at least 2 weeks, and we define neutropenia as an absolute neutrophil count of under 1,000. This was present in over 90% of patients who had a breakthrough invasive fungal infection. These different chemotherapy regimens were present. About 85% had at some point received a low intensity chemo, and about 40% at some point had received a high intensity chemo regimen. About 2/5 had received an allo stem cell transplant, and then about a quarter had received moderate to high dose steroids, which we defined as 20 milligrams of prednisone or some equivalent for at least 3 weeks. And then these were some of the common adverse effects which we looked at and tracked among the different antifungal agents. So we had cardiac, which for the most part was QT prolongation, transaminitis LFT abnormalities, drug-drug interactions, GI upset. So these were things like oral intolerance, nausea, vomiting, abdominal pain, dermatologic manifestations, neuropsychiatric manifestations, including visual disturbances, neurotoxicity and hallucinations, and then respiratory complaints. As you can see, voriconazole had by far the greatest number of adverse effects, even standardized for the frequency of voriconazole use. Part of this could be owing to the fact that voriconazole has a somewhat unique side effect profile with some of these neuropsychiatric manifestations. People will see like yellow colors, hallucinate. Like I've been called about this on the liquid service. So even disregarding this somewhat unique side effect, it did have a lot more cardiac toxicity, liver toxicity, and drug interactions than some of these other agents. And I did just want to highlight the proven breakthrough invasive fungal infections that we identified in this study. As you can see, all of the antifungal agents had at least one breakthrough invasive fungal infection. The most commonly implicated organisms included Mucorales species, Aspergillus, which is kind of a classic fungus when we think about these types of infections, and Candida species. Interestingly, Candida crucei was the suspect in 3 of them. And then one other thing I will highlight is that the majority of patients were either in newly diagnosed leukemia or relapsed refractory disease. So some limitations of this study I did want to highlight is that it is a single center study. So we are limited just by our specific patient population, our demographics, and our local practice patterns. It also was a retrospective analysis as opposed to a prospective trial. And then there were some limitations with the records. In all retrospective studies, you are limited by what's available in the EMR. And there was a lot of times when antifungals were switched without specific documentation as to why. So there very well could have been a discussion between the patient and the provider about side effects or some sort of reason why they wanted to switch, but suddenly the med list had changed and there was no specific explanation as to why. And then another limitation was also with respect to the EMRs themselves. A lot of this data was extracted from our old friend, Sunrise Clinical Manager, from before we switched to Epic. So getting some of the data and accessing it was just a logistical barrier some of the times. And then to just kind of wrap up, I want to give some brief conclusions and highlight future directions for this study. So our incidence of probable and proven breakthrough invasive fungal infection was slightly under 12% at our institution. And this is considerably higher than a lot of the rates which are reported in the literature, which usually are in the single digits at or below 5%. We had a 7.8% incidence of probable breakthrough invasive fungal infection and a 4.1% incidence of proven. The commonly implicated organisms included Aspergillus nigra and Candida krusei. That was the most common risk factor for breakthrough invasive fungal infection. Voriconazole was the antifungal associated with the greatest number of adverse events and toxicities. Transaminitis among the antifungals was a very common adverse event and reason for discontinuation or adjusting of the antifungal regimen. And taken together, the high number of breakthrough infections and the significant toxicity is recommended to use voriconazole cautiously. Our institutional guidelines actually used to recommend voriconazole as the first-line antifungal agent, which is why almost all of the patients had gotten voriconazole at some point. They were actually updated in 2023 to recommend posaconazole or isobuconazonium or Cresemba as a first-line agent. And then there is a larger 10-year retrospective cohort study, which is ongoing, that's going to look at all of the patients from 2015 to 2024 to try to get a little bit more of a robust answer for this question. And I did want to take a moment to acknowledge all of these wonderful people who helped me with this project and collaborated. I wanted to recognize my mentor, Dr. Bott, for all of her help with formulating and coming up with this project. I did also want to take a moment to recognize former ID fellow and now current ID attending Malika Bayreddy, who really helped get this project up and running and get it off the ground. And I inherited this project from her. A lot of wonderful faculty in the ID division, a lot of our great pharmacy colleagues have been helping out, my co-residents, and a whole bunch of fantastic medical students and brand new MDs who helped out with the data collection and processing. These are some references, and I'm very happy to take any questions. Thank you for your attention. Yeah, that's a good question, and that was something that was interesting. It wasn't what we were expecting to see, and the way this was the way this data was explained, just for the sake of time, I didn't go through it exactly. It was really just we took the number of patients who had a breakthrough infection, our 64 patients or so, and how many of them had gotten low intensity chemo at some point. And a lot more of them had gotten low intensity chemo than high intensity chemo. So not all of the patients in this study got high intensity chemo. The high intensity chemo for acute leukemia is pretty aggressive. So if you're an older patient with a lot of medical comorbidities, you don't oftentimes get the high intensity chemo, which I think might be one of the reasons why there is this discrepancy. So I think it was really just related to our patient factors and the types of patients who got certain chemos. Yeah, it's almost like a confounder that I think we could go back and try to control for later.
Very much.
Right. Our next presenter is going to be Dr. Douglas Coursey. And I tried to do it myself. All right. Doug is going to be presenting on clinical performance of novel machine learning-based antiarrhythmic dosing software.
Good morning, everybody. Thank you very much for this opportunity to talk about some work that I've been doing over the last year. So I'm here to let you know about my work with SafeBeatRx, which is a company working to introduce a software using machine learning that will help with antiarrhythmic drug dosing. So the reason why we are looking into this, or first disclosures, excuse me, I do not have any. However, there are a few members who were part of this work who do receive direct payment from the company. So the reason why we're looking into this is because atrial fibrillation affects 43 million people nationally, and the incidence and prevalence of this is increasing due to the fact that age is a risk factor and we have an aging population. The economic burden that is associated with atrial fibrillation is up to $26 billion annual adjusted in the United States. And 75% of the economic burden that comes from that is due to hospital costs. And a big thing with hospital costs is the fact that one treatment option for AFib is antiarrhythmic drug initiation, which in the United States requires at least 3 days in a hospital bed. And there is a move more towards the rhythm control strategy, as with the most recent guidelines now have a class 2A recommendation for the early antiarrhythmic or early rhythm control decision for those with atrial fibrillation in order to reduce CV events, as well as help with things like symptoms too. So another option, you have the antiarrhythmic drugs and you have your catheter ablation. The antiarrhythmic drugs are often chosen, but do have the unfortunate side effect of QT prolongation, which can lead to torsades de pointes, which in the United States, again, requires inpatient hospitalization to make sure that that does not happen. So there are many challenges right now in the treatment of AFib, that inpatient part of it, there's limited access to care and also increases healthcare costs. There's health disparities. Not everybody has the ability to show up to the hospital for 3 days of inpatient care that may be elective versus emergent. There's dosing complexity. You have to monitor the QTC while these patients are receiving these medications. And then you also have to actually check the QTC. We have the ECG printouts, which reads it for us. But if you want to be diligent, you take out your calipers and you measure it yourself and you make sure that that next dose is going to be given safely. So the hypothesis that SafeBeat is working towards, and this is the overall project as opposed to just this abstract, but the hope is that this SafeBeat software can be used with mobile ECGs in order to guide antiarrhythmic dosing for possible at-home use of this initiation. That will require accurate QTC measurement using things like mobile 6-lead ECGs as opposed to the typical 12-lead that is used within the hospital. We also believe that this software can be used to guide dosing for those patients receiving antiarrhythmic drugs. And all of this will lead to improved access and cost reduction in the care of atrial fibrillation. So for this study, it was a prospective study done at UCSF. They were able to enroll 50 patients who came in for the inpatient titration of either dofetilide or sotalol, 44 of which were on dofetilide, 6 of them were on sotalol. And we did this in parallel to the typical inpatient workflow that was done there. So we had our machine learning, which was developed and then trained and then used on a 6-lead ECG that was taken from the patient in parallel to the attending physician running the service who had a 12-lead ECG. So then you can see this more easily described here with the visualization. So the patient's there. They get their normal standard care, 12-lead ECG. Doctor reads the ECG, decides on the next dose of the antiarrhythmic drug based on that. And then they were also at the same time taking the mobile ECG, getting a 6-lead, running it through the SafeBeat software, which you can see an example of the user interface there, goes right to the physician's phone. And then both of those, the physician as well as the software, were making recommendations on the next dose of the antiarrhythmic drug, which eventually the clinician, the attending physician, made a decision on what to do. But they took that suggestion from the software into account. So in order to analyze the data, we just did like the descriptives of the patients who were involved. We also checked the QTC measurement from the application compared to the gold standard, which was the attending physician read. And then we also checked, which was the main outcome, the congruence between the dose that was suggested by our software compared to the dose that the attending physician chose to do. And the way that because this was a safety thing more than anything, so we said if our dose was either equivalent or less to what the attending said, we thought that that was okay and considered that congruent and like a yes, a positive. So what we found was that in our 50 patients who had a mean age of 67, 64% male, mainly Caucasian, baseline QTC was 434, and they all had good kidney function. There were a total of 272 mobile ECGs that were analyzed during this time. The QTC accuracy between the software versus the attending physician was 18 milliseconds, and the literature gold standard for inter-observer variability is 20. So that was within the reference that we had hoped to hit. We found that 245 out of the 264 doses that were recommended, or 92.8%, were congruent between the software and what the attending physician had suggested. So, and this also led to, during the entire period, no adverse events seen on any of the patients while getting these medications. So there was a strong correlation between that observed QTC and the physician measured QTC, and the accuracy was comparable to a standard 12 lead when using this 6-lead mobile ECG. We do have a few limitations that need to be addressed when looking at this work. It was done in the controlled inpatient setting. Eventually, if this is supposed to be allowed to be used in the outpatient, we will need safety and accuracy shown in the outpatient setting. The measurement variability, we don't know exactly what the attending physicians did. The gold standard would be to use the caliper. Some may just look at that QTC that's printed out on the ECG. The population was a pretty limited one in that it was only 50 people. And then the single center of design also limits generalizability of these findings. And we lack any long-term follow-up to see what the safety was after those 3 days of antiarrhythmic drug initiation for those patients. So in conclusion, we have proven accuracy of the software that is used on the 6-lead mobile ECG with almost 93% agreement between the cardiologist determined antiarrhythmic drug dose as well as the software recommended. The versatile application is very easy to use. Patients have a patient-centered one, and then physicians have theirs too. So it also does allow for more transparent communication on what's going on between the physician and the patient. It also will lead to improved access, as hopefully this can allow people to either have part of their stay in the hospital, so less than 3 days, or potentially in the future, the entire thing done in the outpatient setting. And then we have pretty good ideas of where our future direction needs to go. We need to enroll more people. We need to do this at more centers. We need to get past just like the phase 1 safety outcomes and actually start looking at the feasibility of it working as a way to have the same like safety as also efficacy endpoints when looking at it compared to the standard inpatient one. And then eventually too, cost effectiveness will be needed to be analyzed to make sure that everything that we believe about the cost of this is true, that we're saving costs down the line when using this workflow. So thank you very much for your time. Open to any questions if anyone has them.
The size of the next study, give a sense, I guess, what the rate of these events might be. So you have an idea how big a study you're going to need to test those.
Yeah, so in terms of like what the rate of adverse events is with them.
Enough adverse events to happen so that you can show that you've reduced the number of adverse events, or at least not having higher rates.
Yeah, so there's a few different studies that I've done with this group looking at it. I think like QT prolongation can happen and up to like 30 to 40% of people undergoing these initiations, and that's just above the 500 milliseconds on either of those would be considered QT prolongation. Torsades is much more rare though, and then any type of actual like VFib or need for cardioversion is even more rare. So I don't have exact numbers on how big the next one will need to be, but I know that we'll use those statistics when making the power calculations for those. Thank you.
I gave up. All right. Very good. So our final presentation is going to be from Carlos Rivera, our endocrine fellows, and this will be on gluconeogenesis on triglyceride synthesis in SLC 16A11 variants.
Everyone, I'm Carlos Rivera, one of the endocrine fellows. The title of my research project is gluconeogenesis and triglyceride synthesis in SLC 16A11 variants. My mentor is Dr. Ankit Shah. Welcome. I have no disclosures to report. A little bit of background. The SLC 16A11 gene is expressed in the liver and codes for a transmembrane lactate transporter. In 2014, William and others found that individuals with this variant have an increased risk of diabetes type 2 by 25%. And the variant involves 5 DNA-based base changes, leading to 4 missense amino acid changes in that transporter protein, as you can see on the right side. We have the variant, the base pair changes on the top, and then quote unquote normal on the bottom. And then it gets transcribed into a protein. And you have the 4 missense mutations here in red. There's also a silent mutation here, labeled back. There's a 25% prevalence of a risk allele in the Mexican populations, which may explain the increased risk of diabetes in this population. As you can see on the table at the bottom, you have the Hispanic community. This is the incidence of diabetes type 2, and then it's broken down into different nationalities. So you can see percentage of men that are Mexican with the incidence of diabetes is the highest among this group. And then females have the second largest incidence of diabetes after Puerto Rican females. Bit of background. So there's some in vitro studies that show that diminished function of this gene leads to higher amounts of several lipid species, including triglycerides, that you can see on the right side. This study was done in human hepatocytes where they injected a small interfering RNA to knock down the gene. They just found out that there was an increased risk of increased triglyceride species extracellularly. There was also an in vitro evidence that showed reduced transport function with the variant protein. This study, as you can see on the right side, this is where the bars are. They were done in kidney cells. They did the same thing. The blue bar is the ones with the knockdown gene, which basically showed a decreased transport of lactate across the membrane. The glycerol and lactate, as well known, are both gluconeogenic substrates used in the liver to make new glucose. And with reduced lactate transport to the liver, maybe there's more hepatic reliance of glycerol metabolism. So if you knock down this arrow, maybe more glycerol is being utilized for glucose production. And this is the main cornerstone of our hypothesis. Basically, that subjects with the variant gene, there's a shift in the liver leading to increased glycerol utilization for glucose and triglycerides. And this is basically knocked down here, the lactate went into the liver. So perhaps there's more glycerol being used going into the liver for glucose and triglyceride synthesis. And why is this important locally? So from the 80s and 90s, there was an increased wave of Mexican migrants from the state of Oaxaca. This is a nice map here down at the bottom. Here in gold, that's Oaxaca. Just as a side note, part of the reason why I joined this study is I'm also Mexican. I'm from the state of Sonora, it's up here in green, but ironically enough, there's nothing green there. This is all desert. By 2010, Mexicans made about 25% of New Brunswick population, and the current census estimates that there's about 16,000 Mexican Americans living in New Brunswick. So this was a cross-sectional study consisting of 2 cohorts with adults with type 2 diabetes, Mexicans. Half of them were wild type, meaning they didn't have the variant, and the other half had the variant. We screened them. We got informed consent to get a blood sample and send it for genotyping to see if they had the variant or not. And we sent that to a company called Sample in Piscataway. Once we got all the cohorts, we injected a 13-label carbon glycerol infusion in the clinical research center after an overnight fast. We instructed the patients or the subjects to hold their diabetes medication for 3 days prior to the infusion. You can see a nice figure here at the bottom. You have the tracer connected via pump, then connected via intravenous access to the patient. And then we collected the sample. The tracer is depicted here in red, and the trace C, which is the normal glycerol 12 carbon that the patient is circulating through the body, it's in black. Then we collected blood samples at time 0 every 60 minutes for 6 hours. Then after we collected the samples, we send it metabolomic analysis for a mass spectrometry analysis. Our subject characteristics were pretty much about the same and indistinguishable. Most of them were older adults, overweight, and their labs were, again, pretty indistinguishable from one group to another. So what do did we do with this data? We basically calculated the glycerol contribution to fasting glucose production. And you may ask, Carlos, what does that mean? Basically, if you measure the patient's circulating glucose, we try to assess how many carbons came from that tracer. The shortest answer, not the most accurate, but it's just for simplicity purposes. So how did we do that? Basically, you have a patient got the tracer infused, and we calculate the enrichment. Basically, we analyze how much carbons were found in that glycerol that it was circulating in the patient's body. Then we did something called a downstream enrichment. Same thing for the glucose. We measured the circulating glucose of the patient, and then we saw how many carbons were coming from that initial 30 level carbon glycerol infusion cell. And then we divided the glucose enrichment over the glycerol enrichment, and that's how we came out with the glycerol contribution to glucose in these patients on their fasting states. And we analyzed both the wild type and the variants, and they were basically very, very similar, maybe just a difference of 1% against one another. We also did the same thing for circulating triglycerides. This is just a triglyceride molecule, 3 fatty acid chains linked to a glycerol molecule. And we use the most common species of triglycerides found in humans. And we also saw the same thing compared to wild types with the variants. Some of our study limitations. Obviously, we have a very limited N number. There's, interestingly enough, we had 5 patients who were heterozygous with the variant, and then we also had 1 patient who was homozygous recessive. We don't know yet what the implications are in the homozygous recessive variants. Our studies also limited the glycerol metabolism. We're not looking at other metabolites, such as lactate, amino acids, glucose, etc. And based on the research, glycerol incorporation into serum glucose triglycerides doesn't vary based on the SLC1611 genotype, and the biochemical mechanisms linking the variant to diabetes remains unknown, although it doesn't appear to be glycerol mediated. I wanted to give a special thanks to all the study participants, all our nursing pharmacy staff from CRC, Sophia Chapman, one of our medical students, I'm not sure if she's here, and also to everyone who has helped fund this project, including the Endocrine Fellows Foundation, Philistine Medical Foundation, and our beloved Dr. Luis Amorosa, who is sitting here with us. So I wanted to thank everyone, and I'm open to any questions.
I wish we talked about this a little more ahead of time. You know, when you hear about life. So I think if I look. 5% of Mexico. Anybody thinking along these lines to explain this phenotype of 25% diabetes? And, you know, has anybody entertained that hypothesis? Are your results with glycerol, you know, reconciled with maybe changes in NAD?
So the question was, I'll just kind of summarize it, paraphrase it. If there's, since this is a lactated transporter, and sometimes pyruvate is also kind of similar. It actually also helps with pyruvate transport across the liver. It's been studied before. And Dr. Amoroso also asked if there's been some, I guess, studies behind it or seeing this, especially the NAD plus over the NAD-H ratio. And the answer is yes, Dr. Amorosa. There's been some studies that have shown that in this variants, you have decreased NAD plus to NAD-H ratio. And there's, so the liver, in order to kind of equilibrate that, it tends to activate the different enzymes called desaturases. And this leads to an increased unsaturated fatty acid accumulation in the liver, which they think leads to lipotoxicity and insulin resistance. I'll send you the papers.
So say that there's no effect because of that.
Yeah, that's one of the limitations. Hopefully we can expand our studies. Thank you. Is that the way?
6, but the p-value is only 1, 2.
Yeah, well,
60.
yeah, I mean, we can work on that. Yeah, again, this is one of our limitations, but it's a good start. Yeah, that's the thing. You know, increasing the end, we can increase the power.
Very good.
Thank you.
Okay, so I want to thank all of the presenters for a wonderful job. I want to thank the audience here and online for participating. I'm now going to invite all of you to stick around and view our trainees posters that are out in the hallway. We're going to break now, and we're going to come back a little after 10 o'clock, reconvene here for our awards presentation. So enjoy the posters. I told her that we were all going to probably be busy, so yeah, it's no problem. They don't really need us. Thank you, David. Yep. I probably missed some questions on chat, but
No,
okay, good.
no, it was all just me letting people know.
Well done.
Fantastic.
They all showed up.